thank you for joining us today for the MDA Industry Update webinar, More Than Medicine, How Wellness is Influenced by Everything You Do, which is presented by UCB. Please note that today's session is being recorded and will be available for playback on mda.org in the coming weeks. Our Community Industry Update webinars are programs which provide information and updates impacting care and treatment directly from pharmaceutical, biotechnology, and medical equipment companies. These webinars are just a part of MDA's overall community education program, and we encourage you to visit the community education pages of mda.org. There you will find an abundance of resources, recorded webinars like this one, and listings for upcoming educational events. Of course, if you have any questions or need assistance, the MDA Resource Center is available to you by email at resourcecenter@mdausa.org or by calling 833-ASK-MDA1. That's resourcecenter@mdausa.org or call 833-ASK-MDA1. Or you can reach the Resource Center on mda.org. Cameras and mics are turned off today for a smoother experience, but we do hope to have time to answer any questions at the end of the program. So please feel free to make use of the chat function, which is the dialog bubble at the bottom right-hand corner of your screen, to ask our presenter any questions. And now I am honored to turn it over to Judith Thompson from UCB for today's webinar.
Thank you so much, David. I am bringing my slides up, and while I do, I just want to also extend my thanks and gratitude for everyone attending the session today. So let me make sure this is down. Let's just move that in the corner. There we go. Good afternoon, everyone. Good morning, actually, to our folks joining us from the West Coast. Welcome to More Than Medicine, How Wellness is Influenced by Everything You Do. I also want to thank MDA for the opportunity to present this content to you for the Industry Update webinar. I understand we have a majority rare community focused audience today. And when presented with the opportunity to discuss this content with you, I was extremely overwhelmed with joy because this content is something that's usually reserved for our healthcare professionals and the other stakeholders within the healthcare community. But as we begin to talk about how everything you do influences your wellness, I understand that it's the community that's living with chronic illnesses, living with rare diseases, that's actually responsible for the activities that influence wellness. And thus, the information needs to be cascaded down to the community level as well. So I'll open with just our objectives and agenda. And the agenda is really doubling as the objectives here. I'll do a short introduction of myself, but also because we have a community-based audience here, I want to also introduce UCB for those of you who may not be familiar with the organization. I then want to move into social determinants of health, defining them, what they are, why they are important, and also how they may contribute to health inequities in general. And then we'll also move into a little bit of a presentation around health inequities in rare disease. And lastly, we'll cover UCB's commitment to rare disease, as well as some successful program examples and some of our other therapeutic areas. So again, I'm Judith Thompson. I'm a pharmacist by training. I also have a background in public health. I practiced at the community and clinical pharmacy level for over 10 years before I came to UCB. And my current official title is Population Health and Patient Engagement Strategy Lead for Rare Disease at UCB. UCB is a global biopharmaceutical company with our global headquarters in Brussels, and our US headquarters are right outside of Atlanta, Georgia. We were founded in 1928 and recently celebrated a 90-year anniversary. And I say recently, it was a couple of years ago, where we celebrated 90 years of innovation. We were then and still are committed to improving the lives of people living with severe conditions. And that commitment that I'll discuss today is specific to population health. So I do want to give a little bit of a definition around population health, just so we can all level set and start from the same foundational knowledge. Population health is a discipline, right? And it is concerned with the study of the distribution of outcomes of a given population, but also within that population, how those outcomes are distributed. So those that are doing well, those are maybe not doing so well, how the disparities are existing within that population, and what may be some of the contributing factors that are contributing to wellness or lack thereof. And so I think that sets the stage well for our discussion today, because those contributing factors are collectively referred to as social determinants of health. Social determinants of health. There's a lot going on this slide, but I do want to say the key takeaway is that the factors contributing to health and wellness, hence the title of the presentation today, are collectively known as the social determinants of health, right? These are the components that contribute to the wellness. So I could have elongated the presentation name to say, how wellness is influenced by everything you do, by where you live, by what you eat, by how you interact with others. But I shortened it to just be concise. So wellness is impacted by everything you do, and those things that you do and how you live, work, and play are known as the social determinants of health. In fact, if we look at the CDC's definition at the top of the page, they define it as the conditions of the places where people live, learn, work, and play that affect a variety of health and quality of life risks, and also affect outcomes. The World Health Organization is a little bit more specific with their definition, and where they specify that these are non-medical factors that influence health outcomes. These can be more important than the healthcare system delivery, traditional healthcare system delivery. These non-medical factors can be more important than lifestyle choices and how they impact health outcomes. So on the right-hand side of the screen, you actually see a depiction of the 5 categories of the social determinants of health as defined by Healthy People 2030. And so we'll dig a little bit into each of these categories of SDoH, otherwise known as the social determinants of health. The first one is economic stability. So people with steady employment are less likely to live in poverty and more likely to be healthy. That's just what the data tells us. But many people have difficulty finding and keeping a job. People with disabilities, with injuries, or with chronic conditions may be especially limited in their ability to work. In addition, many people with steady work still don't earn enough to afford the things they need to stay healthy or to achieve optimal wellness. For example, sometimes it's hard to afford better choices. If you take, for instance, fast food, how you may be able to feed your family if you're financially constrained at some of the fast food restaurants with a 4 for $4 menu option, or some of the fast food restaurants offer a 99-cent kids meal if you purchase an adult meal on certain days of the week. Another example of that is that canned soda is less expensive than bottled water. And then in some instances, companies won't even place their businesses in areas where they don't think people can afford to choose their healthier options or their healthier products. And this creates food deserts and a lack of healthy choices in those communities. If we look at education access and quality, the data also tells us that people with higher levels of education are more likely to be healthier and live longer. Some people live in places with poorly performing schools, and many families can't afford to send their children to college. The stress of living in poverty has a psychological effect on children's brain development. It makes it harder. It makes it harder for them to do well in school. So that's a cyclical effect of education and an economic stability that's being manifested in the educational system and in health outcomes. Language and literacy skills are also dependent upon education access and quality. And when we talk about specifics to the healthcare system, health literacy is a significant contributor of self-advocacy, to empowerment, to engagement with a healthcare provider. And it also plays a significant role in how compliant a person will be when they're given the care plan by their provider. Oftentimes, as a community pharmacist, my patients would come in to pick up their prescriptions, and they wouldn't have a clear understanding of what medication they were taking or how they were supposed to take it, what they were taking it for. They also may not have a clear understanding of the details surrounding their diagnosis and what they can expect when they take the medication, or what they would expect if they decided to skip out on the medication or not take the medication at all. And that all surrounds health literacy, or being able to make informed decisions based on the information that pertaining to health that the provider has given or that you can consume off from other sources. But are you able to digest and consume that information and then use it to make appropriate healthcare decisions based on your health literacy level? And Healthy People 2030 has grouped that under the education access and quality category. If we move to the third category, which is healthcare access and quality, about 10% of people in the US don't have health insurance. And so people without insurance are less likely to have a primary care provider, and they may not be able to afford the healthcare services and medications they need. Some people don't get recommended healthcare services like regular screenings or immunizations because they don't have a primary care provider due to lack of insurance or lack of healthcare access and quality. Other times it's because they live too far away from a healthcare provider who offers those services. And this is particularly important in the rare disease community, as we know the number of specialists for the variety of rare diseases is already limited. And so we'll speak a little bit about geographic barriers and other barriers to optimal healthcare access when we go to some later sections of today's presentation. Next, we'll move to neighborhood and built environment. The neighborhoods people live in have a significant impact on their health and well-being. Many people in the U.S. live in neighborhoods with high rates of violence or unsafe air or water and other health and safety risks. Your zip code is now known to be one of the single biggest predictors of your life expectancy. And even neighborhoods within a few miles of each other with different zip codes may have 5 or even 10-year differences in life expectancy. Racial and ethnic minorities and people with low incomes are more likely to live in places with these risks. In addition, some people are exposed to things at work that can harm their health, like chemicals or secondhand smoke or loud noises. Neighborhoods also contribute to a person's culture, so how you were raised. Cultural background coupled with ethnicity helps to form a person's perspective. It forms their behaviors and health behaviors, as well as their attitudes and belief regarding healthcare. This is a critical social determinant of health to predict health outcomes. You may have heard of neighborhood walking or biking scores. Those have become pretty popular in the past several years. These are a great indicator for social determinants of health. So it answers questions like, is the neighborhood safe? Do they have sidewalks or biking lanes? Can someone who needs to increase their physical activity to increase their health outcomes or to improve their health outcomes do so in that neighborhood for free by simply just stepping outside? Or do they need transportation to a park? Do they need to hop on a bus? Do they need to ask someone for a ride? These factors impact the wellness of people living in that neighborhood significantly. The last category presented by the healthy people is social and community context. People's relationships and interactions with family, friends, and coworkers, as well as community members, can have a major impact on their health and well-being. One thing that was highlighted as we were earlier in the pandemic with COVID, as people were on lockdown and under quarantine, was that the social isolation, um, the health risks that social isolation posed were actually exacerbated with existing chronic health conditions. So the CDC highlighted that social isolation was associated with about a 50% increased risk of dementia. Poor social relationships like social isolation or loneliness were associated with a 29% increased risk of heart disease and a 32 increased risk of stroke. So that's really, as it pertains to our aging population. But even if we think about our younger people and the isolation of them not being able to interact as freely with their friends in school and their reliance upon social media, et cetera, there have been studies that have also really elucidated the impact that that has had on their health and wellness as well. Another component that some people consider the sixth category of the social determinants of health that was also highlighted during the pandemic is digital and technical access and quality. Because of some of our rural areas and even some of our urban areas just do not have the infrastructure to provide broadband access to each community with equity. And so that impacts, how our kids were able to log into uh, these Zoom sessions in order to attend school, which plays back into education access and quality. But it also plays into, the ability for people who aren't able to see their specialist or their provider to be able to access telemedicine opportunities so that they can have improved healthcare access and quality. As you can see, a lot of these social determinants of health are interrelated, but together they have an important influence on health inequities. And so we'll move into health inequities next so we can get a better definition of health inequities in general, and as well as health inequities in rare disease. The key takeaway from this slide is that equity and equality are not the same. As a matter of fact, I would go as far as to say that equality is the enemy of equity. And if we look at the image on the right-hand side, we can see the difference in equality and equity, right? Have you ever heard anyone, for example, to say, I don't see disabilities, I treat everyone equally, or I don't see race and ethnicity, I treat everyone equally. Or I don't, look at poverty or socioeconomic status as a factor, I treat everyone equally. Well, treating everyone equally doesn't really solve or address the social determinants of health or give everyone equal opportunities to achieve optimal health. So in the example on the right-hand side of the screen, you can see where equality is pictured as everyone receiving an equal accommodation. Everyone gets one box to stand on in order to see the soccer game over the fence. The first gentleman is pretty tall. He doesn't really need a box, but he has a great view standing on his one box. The little girl in the middle actually has a better view with her box, but she's still on her tippy toes and she's not quite comfortable seeing the soccer game. The third individual in the wheelchair, this accommodation is meaningless. They can't stand up on the box, and thus they're not able to achieve the optimal view. The accommodation doesn't give them the same opportunity to achieve the view that the other two individuals have. By contrast, looking at the far right image, you look at equity. And this is just really a visual representation of how meeting people where they are based on the social determinants of health that they are living within or working and living amongst gives everyone the optimal opportunity to see the soccer game. Some people need no box, some people need two boxes, some people need a ramp built for them. But whatever their accommodations are, they're equitable because now everyone has the opportunity to achieve optimal vision or visibility of the soccer game. And it's no different in healthcare. Health inequities can be defined as unfair and avoidable differences in health status. So if you look at the picture again, it's unfair that the individual in the wheelchair, when treated equally, does not have the opportunity to see the game. It's avoidable. That difference does not have to exist. And in healthcare, these differences can actually, or these inequities can actually lead to health disparities. So if we think back to the definition of population health, those disparities were the differences that we saw within a population between those that were doing well and those that were not doing so well. If we think about the diagnostic odyssey and treatment journey in rare diseases, these health inequities may actually exacerbate those challenges, and they can present such as barriers to adequate testing or adequate screening for the rare disease. We lightly touched on geographic barriers earlier, but in a rare disease space where there's already a limited number of specialists, where someone lives may just add to the appropriate diagnostic journey, the time to diagnosis, or even receiving optimal treatment because you're able to visit a specialist that really understands the rare disease diagnosis that you have. You couple that with racial and ethnic disparities and unconscious or conscious biases that people may encounter along their diagnostic odyssey and treatment journey, and it just adds to the otherwise challenging journey of living with a rare disease. We call these dimensions of diversity, which means all of the different ways in which we are different. And those dimensions of diversity make every journey unique. And so, again, the key takeaway here is that because of the uniqueness of everyone's journey, equality and equity are not the same. And what we strive for is health equity so that everyone can get the accommodations that they need and have that opportunity at optimal health outcomes. So UCB's commitment to population health is actually spelled out now on our ucb.usa.com website. So on the right-hand side is actually a screenshot of our landing page. And if you visit the ucb.usa.com website, you'll actually see that this site gives an overview of our population health activities across all of our therapeutic areas. And it also provides some additional links to some of our available resources. In terms of our programs, successful programs that we've been able to actually initiate, and some of them have already been completed and are available, as well as on our UCB USA website, you'll be able to see a couple of press releases for some of these programs. But we'll start with the Community Health Fund. The Community Health Fund is actually a global community health fund that has an impact all over the world. So we launched this program in the summer of 2020, and to date, we have supported over 99 organizations around the world with nearly $5 million in support to vulnerable populations. If we move into our epilepsy-specific programs, we published a paper last year. We published the findings of a database analysis that was conducted in partnership with Arizona State University on the social determinants of health and their impacts on epilepsy treatment delays. The analysis included people with epilepsy in the Arizona Medicaid population, and the social determinant of health factors that were predicted to impact treatment delays included healthcare setting, age, race, marital status, homelessness, and employment. Another epilepsy program that was successful was our Hispanic Care program. And we initiated this program to better understand the experiences of Hispanic people living with epilepsy, and also that so that we can improve our collective effort to break down barriers to equitable health outcomes. We worked with patients and their families, as well as health equity experts. And as our first step, our team gathered insights from healthcare professionals working in communities delivering care largely to Hispanic populations. We then convened patient focus groups to hear directly from Hispanic people living with epilepsy, specifically those of Mexican heritage, to help us learn more about their experiences and what resources may be beneficial. In those focus groups, two key obstacles emerged. The first was cultural misunderstandings and oversights, and the second was the need for native language disease information and resources. So as a result of this program, we've improved the way we engage with the Hispanic community. And we are still making incremental changes to bring value to people living with epilepsy of the Hispanic community, but also people, Hispanic communities that are that belong to some of our other therapeutic areas. The last epilepsy example is Exploring Epilepsy. And this is a website that we developed several years ago that contains educational content about epilepsy that's delivered at a comprehension level with tons of images. It's easily consumable. And we did this so that people with lower health literacy, those that speak English as a second language, as well as the aging population can see a visual representation of the educational material, but also the content is written at a fifth to sixth grade level so that it's easily understandable. The goal of this site was really just to activate people with epilepsy and their families to be an active part of their healthcare team and their healthcare journey by empowering them through education. If we move on to Wellness for You is a peer-to-peer speaker program with within a larger series of programs that brings attention to health equity and immunology. The goal of this program is to inform and guide participants so that we understand and that the participants understand, and collectively we can address unmet needs in immunology in an effort to advance patient care and improve patient outcomes. Some of the patient populations highlighted in the Wellness for You program include women, populations considered skin of color in dermatology, that's huge, as well as the LGBTQIA plus population. And then Rebuilding Together, which is a partnership with a Silicon Valley nonprofit entitled Rebuilding Together. We teamed up with them, excuse me, as an organization to repair homes for older Americans or for people living with disabilities who are physically and financially unable to maintain safe living conditions. And so in this program, we actually had UCB employees from across the country joined by volunteers from O'Connor Hospital and other area organizations to work on a home in San Jose, California. The 74-year-old occupant of that home broke her hip several years ago and suffered some other fragility fractures. The effort actually helped this homeowner live independently and reduce the risk of future falls at her home. So, in the rare disease space, we are committed to continuing to understand the needs of the rare community. Through the successes in our other therapeutic areas, we have gleaned key learnings and key insights that will help us determine how best to invest our time, how to invest our efforts into programs within the rare community, and then who we need to work with to create these programs so that we bring the most value to the rare community. We have engaged in several learning opportunities, and we've completed numerous listening exercises with a variety of stakeholders in the rare community that will aid in our understanding. But we are not done listening. We will continue to grow and learn from and with the rare community so that we may continue to build together. So thus our mission in rare disease is clear. Our mission with generalized myasthenia gravis is to develop transformative solutions that can improve outcomes for people living with rare conditions by delivering meaningful improvements to the standard of care. By aligning our goals to the needs and objectives of the GMG community, our approach to innovation and partnership informs not just the treatments we develop, but also our wider contributions to support and care. And with that, I'd like to say thank you again for your time. Today, I will open it up to see if there are any questions.
Well, Judith, as we wait to see if any questions come in the chat, I did want to just take a second to thank you for the education and awareness that you provided today. There was some new bits of information to me and a couple things that I'd heard before, but definitely needed to hear again. So thank you so much for that. And I a second to thank UCB for all of the programs that you listed, but especially for that $5 million that you put into the community health program, the community health fund. That's just amazing. And I do see that we are already at the half hour, so I think we may have a couple questions coming in. I think the best way to handle that is if we include those questions, the answers to those questions that we see in any email follow-up that we will be doing. And with that, I just want to thank once again UCB and Judith for the time today and the support for the Muscular Dystrophy Association and the neuromuscular community. We've hoped that everybody here has enjoyed this presentation. And at the end of this webinar, you're going to receive an email with a survey link. Please do take the time to complete that short survey so that your voice is heard and you can help us create more impactful programming for future events. So on behalf of MDA, thank you all again for joining and happy holidays.
Thanks, everyone.